Welcome. This is Jason Clemens, Doctor of Chiropractic at the Rock Health and Wellness Center, and this is Life with Jason Clemens, DC. We are live right here in the Rock Health and Wellness Center studios. We're a little banged up, but we made it through the storm last night. Sorry, I lost my train of thought last night. Right there at the middle, got these tornado warnings going off, and I didn't know if I needed to duck and cover or not. So apparently. Boy, we lucked out. But we're live. We're here tonight. It's Friday night, June 6th. We're in the Rock Health and Wellness Center studios. We're on 98.7 Walk by Faith Radio. We're on 1490. We're on 987radio.com. And maybe we're on 1420 instead of 1490. I can't look at the weather app and talk at the same time. So I'm going to turn the weather app off for the rest of the evening. Last night was a big old storm headed right towards Lubbock, right about the time we were getting off the air. And we got some small tornadoes touched down to the west of us, and we weren't sure what was going to happen. So the tornadoes stopped, and then we got straight line winds and hail like crazy. It looked like a war zone around here after this morning when we went for a walk and busted some windows here in the building. And the whole side of the building faces the north, and that storm came in from the northwest, and there's lots of places around town. People's cars got busted all up and totaled, and we went for a walk this morning around our neighborhood, and there was lots of windows broken, probably 50, 100 windows we counted this morning that were all busted up from the hail. But I haven't heard of anybody, any injuries or anything. That I think that was very minimal if there were. So we were thankful for that. I was really thankful that, we didn't get that tornado. So I don't know we got some more weather going on tonight, but I think it's going to be north of us, but we'll find out here shortly and see how it goes. But hey, we had a good week. We had a good week of shows, and we had several different articles we were going through. We went through my blood work early in the week. If you didn't get to watch that one, it's a great one. I think we did it on Tuesday maybe. But go back and watch that if you're interested in blood work analysis and some things that you might could do to help your blood work. We went through an article. We got through the article of non-pain relieving options or pain relieving options that were natural. And then last night we got into a little bit of an article of forward head posture. And so I've got an article pulled up that I want to go over tonight. And there's I had an interesting conversation with a person today that made the question or made the statement, how do I know if this is going to work? And before I make the commitment, they come in as a new patient. We go through their new patient exam. We check it all out. And they ask the question, how do we know this is going to work? And you guys that listen to the show, and you guys that watch the show, I've tried to give you everything possible. I mean, we're a year and 8 months into this thing, and 5 nights a week. I think that the listeners of this show, you finally get it. I think you have a way better understanding than what the person that was asking me the question had as an understanding. But I thought I would just take just the thoughts that we had from this week and add this article that I wanted to talk about anyway, and just add it to the list tonight and see if we could get a big picture and just bring it all together. Because is there anything we could do to say, how does neurology, how does nutrition, how does mechanics, how do all of those things fit together in trying to help me be better? And where does chiropractic fit in the middle of all that? How do I even know what is going to happen when I get adjusted? I mean, it's kind of like going through my blood work this week and trying to show you, look, 3 years and 3 months of no sugar, and here's the results of that. And when I say 3 years and 3 months, I'm talking about no pieces of bread. Haven't had a piece of bread, no pasta, no rice, no sugars, no candy bars, no Dr. Pepper's, no nothing. No ice cream, nothing. I went and got a haircut today, got out of the car, and I looked next to me at these two people sitting in a pickup truck eating looked like some sort of sundae that they got from Dairy Queen or something. And I was just looking at them, and I was like, I started to stop and tell them, you all know that's poison for you. But I didn't. I just kept on going. I just walked on by and I just thought, yep, that was a time in my life I used to do that. But when you do that and then you get your blood work done, then your A1C is low and your homocysteine comes down and your cholesterol is low and all of those things, like you don't have sleep apnea and you're not wearing a CPAP machine and you're not having to take all this stuff and it's just like, well, that's one way to show you that it works. That's one way to say, hey, look, that's the way it works. But I thought that's what we would do tonight, and I thought we'd kind of try to pull this whole thing together and really just maybe take little pieces of what we have talked about and then just pull them all together and say, okay, this is what we're going to do. Just from a technical standpoint, really. Just, I don't know. We'll start off with just the brain. That's where I want to start is with the brain, because I want to answer the question, like what if this what if you're unsure if this is going to work, is what I actually wrote down, right? So let's look at the brain and let's say to ourselves, okay, number one, does our brain have anything to do with our health? Like if you were to stop for just a second and just ask yourself, like, is my brain controlling my health? Does my brain have anything to do with my health? Like anything you want to pick. You can pick any disease process on earth. You can pick any problem that you're having, your knee, your hip, your foot, your shoulder, your sleep problems, your anxiety and depression, your gout. Just pick your thing, right? Just pick anything at all and then ask yourself, does my brain have anything to do with this? And then ask yourself, what happens to a person when you cut their brain off from their body? Not literally like cut their head off, but what happens when you, like, go look at Christopher Reeve. Remember, that's a person, that's a 6'3" athletic guy, and then that's a guy in a wheelchair. And the difference between the two is that one of those guys, the guy that's the 6'3" athletic guy, his brain and his body are talking to each other. And the guy that's in the wheelchair, his brain and his body are not talking to each other. And you just think about for a second, what if my brain is not talking to my body? Is my body going to function the way it's supposed to function? And the answer to that question is no, it's not. Now you got to ask yourself, how much different am I than Christopher Reeve? If he is, let's just say for the sake of conversation, that he's 100% decreased in the communication between his brain and his body. And he wasn't 100%, but there was a lot down. I don't know what the percentage was, but let's just say he was 100%. How far are you willing to go with your health towards zero? I mean, from zero towards 100% disruption, how far are you willing to go from I have no interference in my nervous system to I have complete interference in my nervous system? How far are you willing to go before you are concerned about that? Just you personally. Like do you say, you know what, if I have 15% of my brain and body disconnected, then that's enough. Like, I'll be all right with that. I'll be fine if 50%. What if 75%? I'll go all the way that far. Just take 75% of my brain away from my body. And no, I don't think people would say that, really. I mean, I don't really think a person would really want any part of their brain not talking to their body, right? So we know we've got lots of evidence that the brain and the body are connected with each other, and that the brain is directing what's going on in the body. And if you wonder what Christopher Reeve died from, it's a bed sore. It's an infection of a bed sore. And you may ask yourself, why would he have an infection in a blister? Like, why would he get a blister or a bed sore and get an infection and die from that? Like, I thought chiropractic was this back pain thing. I thought chiropractic was this musculoskeletal back pain thing, but now you're pointing out to me that the subluxation and the interference in the nervous system has something to do with my immune function as well. And it's like, see, I think the more times you hear these stories and the more times you make those connections, like, wait a minute, my nervous system and my immune system are connected to each other. Your nervous system and your sexual organ function are connected to each other. Your nervous system and your cardiovascular system are connected to each other. That was one of the things my brother-in-law got me on. He said, would you let me take a pair of scissors and cut the nerve that goes from your brain to your heart? And I literally looked at him and just thought in my own head, I really literally did. I thought in my own head, there's a nerve that goes from my brain to my heart? Like, when did I miss that class? Every time we ever talked about the cardiovascular system, from the time I was born to the time I graduated with my master's degree, every time we talked about the cardiovascular system, we just talked about the heart and the lungs and the blood vessels, the arteries and the veins. That's what we talked about. Like, I don't know, maybe I missed the day that we talked about how the nervous system is the one that runs that deal. Like, what is AFib anyway? A lot of people are in that now. A lot of people are like, all of a sudden they got AFib. And it's like, well, what is that? It's an irregular heartbeat. What's making the heart beat? Why is it beating irregularly? What is going on with that? Is there a nervous system component to that whole thing? There actually is. What if you cut your brain off from your heart? How long do you think your heart would last? Not very long. Like, it wouldn't last very long at all. You ever sat down in a chair and stood up really fast and gotten dizzy? Why? Why did you get dizzy? Because you lost blood supply to your head. You lost blood pressure to your head for just a second, and it made you very woozy and dizzy. Like, whoa, like all of a sudden the world is spinning. Because you stood up, and what happened? The blood dropped down into your lower extremities, and what causes the contraction of the muscles that squeeze the blood back up to the heart so that the heart can pump the blood back up to the head? It's the nervous system. It's the sympathetic nervous system in the brain that contracts the blood vessels in the legs to make sure that you got enough blood in your brain. Your brain is connected to every single solitary place in your entire body. And if you don't believe that, if someone were to take a needle and they were to just start to stick you in places in your body, would you feel it? And I'd be willing to say yes. I'd be willing to say that if someone just came along and just started sticking me with a needle, I'd be like, ow, 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 that hurts. And if they went all over my body, they'd be sticking me, and that because they would be hitting nerves, and those nerves would be firing to my brain, and my brain is connected to my body. Okay? So you can't pick out a symptom that doesn't have some sort of nervous system response or some sort of nervous system connection. No matter what you're taking. You're taking blood pressure medication, guaranteed it has something to do with your brain. You're taking arthritis medication, I guarantee it has something to do with your brain. If you're taking cholesterol medication, it has something to do with your brain. If you're taking whatever, we just go through the list of anything you might be taking, and I promise you, there's a connection to your brain. So, now that we've established that part, we say, hey, look, okay, All right, I give you that. I'll give you that your brain, my brain is connected to my body, and that there's a problem going on. I mentioned it to one guy today. I asked him, he was face down, he rolled over on his back, and he said, "Oh, I'm stiff." And I said, "What'd you do? Eat sugar last night?" And he just started laughing, and he was like, because he's kind of new to my office, and he said, "How'd you know that?" And I said, "Well, because why else would you be stiff? Like, why are your muscles not functioning properly?" It's like sugar's the top culprit in that deal right there. You wake up stiff, you can't turn over. It's like, oh, I'm stiff. It's like, and and he's a thin guy. He's a thin guy. Doesn't have a weight problem at all, but his body is got degenerative joints all over it. And I tried to explain to him. I was like, look, we got to get off of that sugar for your brain, not just for your knee, not just for your hip, not just for your low back. We got to get off of the sugar for your brain, because guess what? Your knee problem and your hip problem and your low back problem were secondary to your brain problem. It tells me that your brain is already having a problem when you have a low back problem, a hip problem, and a knee problem. And I know that's a little hard to understand at first, but I promise you that's the case. Unless there's an acute injury to the knee, it happened in the brain first. That hip is rotated, it's degenerative. The knee is rotated and degenerative. Why did the hip and the knee rotate? Because the brain is not balanced. Something's going on inside the brain. Okay? So we've got brain and body connection. And we need that to function properly. Okay? So I told you about whatever that article, that chiropractor. Yeah, chiropractor with Dr. Glowacki and Dr. Chestnut that I was listening to yesterday, talking about the chiropractor, right? And so they were talking about a study that was done, and this study was talking about the need to get adjusted. And it was actually published in Spine magazine. And this is a randomized controlled trial that was published in Spine magazine right here. And those guys were talking about it. So the title of the article says, does maintained spinal manipulation therapy for chronic, non-specific low back pain result in better long-term outcomes? And the objective of the study was to assess the effectiveness of spinal manipulation therapy, which is an adjustment if it's done by a chiropractor. Okay, the objective is to assess the effectiveness of adjustments for the management of chronic, non-specific low back pain, and to determine the effectiveness of what he's calling maintenance adjustments in long-term reduction of pain and disability levels associated with chronic low back conditions after an initial phase of treatment. So basically what they wanted to know is if someone had an initial treatment with low back pain, and we were to separate those groups, we took a couple groups and we separated them, and we actually kept adjusting the other one just kept adjusting them for a period of time. Would there be any difference when you get down the road, right? 60 patients with chronic, non-specific low back pain lasting at least 6 months were randomized to receive either 12 treatments of sham adjustments over a 1-month period. Second group, 12 treatments consisting of adjustments over a 1-month period, but no treatments for the subsequent 9 months. Or number 3, 12 treatments over a 1-month period, along with what they're calling maintenance spinal manipulation, which I'll just totally disagree 100% with that word, but that's what they're calling it, every 2 weeks for the following 9 months. So you got one group that got a sham adjustment, you got one group that got a good adjustment and no follow-up, and then you got a third group that got a proper adjustment and 9 months of follow-up of every 2 weeks. To determine any difference among therapies, we measured pain and disability scores, generic health status, and back-specific patients' satisfaction at baseline and at 1, 4, 7, and 10-month intervals. So this was published in Spine magazine. This is a legitimate study and a legitimate. This is 2011, August 15th, 36, 18, 14, 27 to 37. Okay, that's if you want to look it up. Here's the results. Patients in second and third groups experienced significantly lower pain and disability scores than the first group at the end of the 1 month period, which we know would be true. The patients who got adjusted 12 times over a 1 month period, so we're talking about 3 times a week for 4 weeks. That's the frequency that they got adjusted. The patients who got adjusted 3 times a week for 4 weeks that had chronic low back problems did better than the people that got the sham adjustment. Now, I know a lot of people would say, you would think it would be the same, because I know a lot of people, they don't even understand chiropractic and they don't buy into the theory, and it's like, whatever, okay? But this article, which is a randomized group, right? They found out if you got adjusted 3 times a week for 4 weeks, you did better. Okay. However, only the third group that was given spinal manipulation adjustments during the follow-up period of 9 months showed more improvement in pain and disability scores at the 10-month evaluation. In a non-maintained adjustment group, however, the mean pain disability scores returned back to near their pre-treatment level. And this is my argument of maintenance. It's not maintenance care if you're going to return to the position that you were in. It's active treatment, because when you stop the treatment, you go back to the position that you were in. After that if you don't do something corrective to get it corrected, then you'll go back. So you get adjusted 3 times a week for 4 weeks, but after 10 months, you're just like the group that didn't even get adjusted. You just go back to right where you started. And I've got patients that have been doing that for 21 years now. I've got patients that they will come in, they'll get adjusted a handful of times, will knock down whatever their pain is, and then they'll come back and see me whenever they have the same problem. And when they come back and see me, they have the same problem. And if you went back through their notes and looked and said, well, I wonder how long this has been going on. It's been going on for 15, 20 years in some of these people. And it's like, why would that person choose to live their life that way? Isn't that an interesting way that a person could live their life? Like, you're just going to be perpetually repeating the same back pain for years and years. And what do we know by the articles that we've studied? That as we get older, the time between flare-ups decreases and the duration of the flare-up increases. We know that, right? So we know this, that the conclusion, adjustments are effective for the treatment of chronic nonspecific low back pain. To obtain long-term benefit, the study suggests maintenance adjustments after the initial intensive manipulative therapy. Okay, then Dr. Chestnut made the statement. He made the statement on one of his podcasts. He said, the only difference between day 1 and day 100 is the frequency of the chiropractic visit. Adjustments, essential nutrition, drinking water. What does an acute patient need that a wellness patient doesn't, and vice versa? That's exactly what this says right here. To obtain long-term benefit, the study suggests getting adjusted after your initial phase of increased frequency. You don't need to get adjusted 3 times a week for the rest of your life. You just need to get adjusted, and these guys did it once every 2 weeks. But why did they do so well? And I'll tell you what I really believe and why they did so well. I think they did so well because, and we said we were going to start to draw this differently, but this up here is optimal health. Okay, there's a line, you draw your graph, and this is where you want to live, right? And what happens is you want to live up here, but then all of a sudden you drop down and you drop down and you drop down, and then all of a sudden you hit this second line, and this is your symptom line. And then when you cross that symptom line, now you've got pain. Okay? I believe that the uh, initial phase of the care brought the person back up above the line. Once they brought it back up above the line, this so-called maintenance care hang on. Well, hang on just a second. We got to take a break. You guys stick around with us. This is Life with Jason Clemens, DC. We're going to put it all together on the second half of the show, so don't run off. We'll be right back. Okay, hang on. I'm having a technical difficulty right there. There we go. That initial phase of care brought the person back up over the symptom line, and they're like, hey, I'm doing better than I was. My pain's decreased. I feel better. I'm functioning better, all that sort of thing, right? And then they got adjusted every 2 weeks. And it kept them on a trajectory that was above that symptom line. The 2-week frequency just happens to be about right based on the stress level of the person. Now, if the stress level of the person was greater than the adjustment frequency that was equal to keeping them above the line, then what would happen is they would start to go downhill. Even though you adjusted them every 2 weeks, if their stress level was high enough, it would be pushing them down below the line. Their physical, chemical, and mental emotional stresses. So that's the way really that we want to address frequency. How much stress are you under? How much physical, chemical, and mental emotional stress are you under that's going to cause you to move downward? So that's why if we can address the physical, chemical, and mental emotional stresses, then we can decrease them and keep you above the line. Does that make any sense? Like, that's because I know patients every 2 weeks wouldn't cut it. They would get adjusted if they got adjusted every 2 weeks. If they got adjusted every 2 weeks, it wouldn't be 3 months and they'd be back into symptomatology again because their stress level is too high for an every 2 week adjustment frequency. These guys got lucky in this article because they had a group of people that their stress levels were enough to where they could get adjusted every 2 weeks and they could be fine. And sometimes it's 3 weeks and they could be fine. But that third week, I promise you, wherever that is, there is a trajectory that's trending downward. And if it's trending downward and you get adjusted and it makes you go upward, to me, that's active treatment. This idea of maintenance care, they say, well, it's maintenance care. We're going to keep you above the line. Well, just move the line. Hang on. Okay, everybody, we're back. This is Life with Jason Clemens, DC. We're trying to put it all together, and we're talking about this article that says the people that get adjusted and the people that continue to get adjusted over the next 9 months are the people that did the best. And I'm going to say that the people that get adjusted over the lifetime are the people that do the best. I think that I've got some I think I've got some evidence on that. I think I've got some lifetime evidence personally on that. And is the adjustment the only thing that a person needs to do in order to be healthy? I don't believe that at all. I don't think you can adjust your way out of bad nutrition. I don't think you can adjust your way out of no sleep. I don't think you can adjust your way out of no exercise. I've adjusted too many people. I know that. I just believe that to be true, right? You got to add all those things together. But that adjustment is a part of it. That adjustment is a big deal. It's a big deal to me because I'm a chiropractor. Of course, it's a big deal because your nervous system, your body, and your brain are connected together. So let's look at this article. Let's look at this article here that talks about the mechanoreceptors in the lumbar spine, the intervertebral disc. Okay, this comes from the Journal of Clinical Neuroscience, Volume 17, Issue 6, June of 2010. I mean, it's not new. It's not new stuff, right? So we got this this article. The aim of the study was to determine the types of mechanoreceptors, meaning the types of nerve receptors in the two lower intervertebral discs in normal adult cadavers donated, and to review the literature. 25 lumbar L4 and L5 and L5 and S1 intervertebral discs were retrieved from 15 fresh cadavers. Okay, so they went in there and looked at 15 fresh cadavers. So what were they actually looking at? They were going in there and they were looking at these lumbar spines. And so if you look at a curve from the side, we're looking at an x-ray for you guys who are on the radio. We're looking at an x-ray and we're looking at it from the side. And we're looking at 5 lumbar vertebrae, 1, 2, 3, 4, 5, and then your sacrum at the bottom. And these guys came in and looked at this L5 S1 disc, and they looked at the L4 L5 disc. Now, I wanted to show you this picture because it's very clear that the L3 L4 disc space is almost gone in this person. Like we have very little. You can see the disc space between L4 and L5 is very thick and open. The disc space between L5 and the sacrum is still relatively in good shape. The disc space between L4 and L3 is just, see how thin that is? It's just almost gone right there. But that's what they went in to see. They went into some cadavers and they went in there to see are there any nerves in that disc? Are there any? Is there any innervation in that disc at all? And the answer that they found was yes. Of course. Why would I show you an article if it didn't match? Right? Okay. So they go in there and they say, all right, here's what we're going to do. We're going to go in there to 25 lumbar L4 and L5 and L5 and S1 disc were retrieved from 15 fresh cadavers. We utilized some process to localize specialized nerve endings. It showed receptors in 92% of the disc. 92% of those 25 discs had nerve receptors in them. Now, remember our rule. This pen, if I hold this pen up and I show you this pen, if there's a nerve receptor on this end of the pen, is there something on the other end of the pen? Can you have a nerve receptor and not have the other side? No, you have the back of the receptor, right? In the lumbar spine, if there's a nerve receptor, there's a nerve. And if there's a nerve, where is the other end of that nerve connected? Where is it going? It's going to the brain at some point, right? The receptor in the disc is connected to the brain. The string has 2 ends. The nerve has 2 ends. If you've got a receptor, 92% of the disc that they gathered had receptors in the L4 and L5 and the L5 and S1 disc. That means that your brain is connected to your L5 disc. You see what that means? Do you get that? Your brain is connected to your L4 and L5 disc and your L5 and S1 disc right there. 92% of them, which is interesting. What was going on with those other 8? That 8%. Why wasn't it not 100%? What went wrong along the way that caused this interference in those other ones? That's a real interesting question that I have. The most frequent type of morphology resembled the Ruffini type receptor, followed by the Golgi type receptor. Free nerve ending fibers were frequently present. All neural structures were found in the superficial layers of the annulus fibrosus, in longitudinal ligaments, or between these two. Okay, all the neural structures were found in the superficial layers of the annulus. It's that outer ring. It's the outer ring of the disc, is that annulus. And the superficial layer is that outer one. So basically, what I've come to understand, it's the outer 1/3 of the disc that's innervated. That disc that sets between the vertebra, you have a vertebra and you have a disc, and you have a vertebra and you have a disc, and you have another bone. So there's bone, disc, bone, disc. In between the bones is the disc. And the disc has an annulus around the outside and a nucleus in the middle, and the annulus has nerve receptors in it. Okay? The anterior part of L5S1 disc had a greater frequency of encapsulated receptors than other parts, which may be correlated with the high shear forces to which the lumbosacral junction is subjected. The presence of nerve structures in intervertebral disc is well documented. These receptors have key roles in the perception of joint position and adjustments of the muscle tone of the vertebral column. These nerves are responsive to change in joint position and alignment, and they control vertebral column muscle tone. An important component of low back pain is intense muscle spasms of the vertebral musculature, elicited through reflex arcs mediated by specialized nerve ending. I can't stress enough what that means, because I've said so many times on the show, people will come into me and say, Doc, is it bone, is it nerve, or is it muscle? My back hurts. I got this low back pain. Doc, is it muscle? Should I go see a massage therapist? Because I feel like I got a muscle spasm. And it's like every single time I'm like, the answer is yes. It's bone, it's disc, it's nerve, it's fascia, it's ligament, it's tendon, it's muscle, it's all of it. It's all of it in a complex that's working together. I need to go get a massage because I have a muscle spasm. How did that muscle spasm? What causes, just do this with your hand. Put your hand up and make a fist. Just make a fist with your hand. How did you do that? How do you make a fist? Your brain tells the muscles in your arm to contract. That's how you make a fist. It's telling the muscles that control your hand to contract. If you have a spasm in your low back, you got a spasm because that nerve fired and caused that thing to contract. Now you can do that chemically with not having enough potassium and water and all that sort of thing in the cells, but you didn't get a muscle spasm for nothing. That's a nerve involved. And what this article is saying is that right here, these receptors have a key role in the perception of joint position and adjustment of the muscle tone of the vertebral column. The lumbar spine receptors are sensing positioning. So many times we've talked about flexion and extension. Flexion and extension of the lumbar spine. And when we spend so much time in flexion, then we push the disc, the nucleus of the disc back into the outer 1/3 and irritate the nerves or vice versa, right? It's like there's a position sense that controls the muscles around the spine. And that position sense are mechanoreceptors or nociceptors, which is also controlling basically the chemistry around the spine. An important component of low back pain is immense muscle spasms of the vertebral musculature. That's a reflex. So now you hit the nerve fires, it fires into the muscle spasms. That's a reflex. That's just like hitting your tendon on your knee. You hit your tendon on your knee and your knee kicks up. Because the tendon, you hit the tendon, you fire that into the spinal cord. The spinal cord has a reflex loop that comes back into the quad muscle, makes the quad muscle contract, and your foot goes forward. That's a reflex arc that happened down at the spinal cord level. But at the same time, it went to the brain. Because you hit somebody in the knee with the reflex hammer. Have you ever been hit in the knee with a reflex hammer? You ever gone to the doctor and they hit you in the knee with the reflex hammer in that tendon, your patellar tendon, right below your kneecap? What does your leg do? It kicks up like that. How many times does it kick up? Once. What if you hit the tendon and it went and just kept going? What does that mean? What does it mean if you hit the tendon and then all of a sudden we got 3 or 4 or 5 of those going on right there? You know what that means? It's a loop. It's a loop that's coming around. There's a loop that's in the spinal canal that is connected to the brain. So we've got the leg, and we got the quad muscle, and then we've got the lumbar spine, and then we've got this whole spinal cord thing going on, and we're going to hit you right in the kneecap with the reflex hammer, and that's going to send the signal into the spinal cord and loop it around back into the muscle, and that's called a reflex. Now, your leg is going to move before your brain knows what's going on. But you're also, at the same time, going to send a signal up into your brain to tell your brain that what's happening down there in your knee. And your brain is going to send a signal back down to turn that off, to stop the loop. And that's you got one shot. So it's going to hit you, you're going to hit it, bam. And your leg's going to pop up, and then it's going to stop. What stopped it? Your brain. Your brain got the signal and then said, no, stop doing that. We're not moving. And it stops it. Versus you hit it, and then all of a sudden it just 4, 5, 6, 7 times, it just keeps going like that. Right? That reflex right there is not, we're losing this. We're losing this somewhere along the way. Either in the spinal cord, either in the process of moving up to the brain, either in the processing in the brain or down from the brain, somewhere in that pattern, we've got interruption. We've got disconnection. And that's why all of a sudden it's like boom, 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 boom. And that's what's going on right there. Okay, so what this article is saying is that inside that disc, we've got a reflex that when you smash that nerve that's inside that disc, it's going to fire these paraspinal muscles on both sides, and you're going to get that intense spasm that's going to go right there. Why did God create reflexes? Have you ever thought of that? Probably not. Probably not. But I'm just telling you, here's what I think. God did not tell me why he did reflexes, but here's what I think. He's like, look, I'm going to set it up so that if you need to move really quickly, before you have time to think about it, I'll set up a little reflex that says disc to paraspinal muscles really quick. And then we'll send them to the brain. Then the brain can decide if we want to continue in that position right there. That's what I think. I think it's like God set it up so that, man, there's times it happens so quickly that you just spasm. Oh, like, woo. And then once you think about it, then you stop spasming, right? So that's what the article is saying. The article is saying that there's a connection. There's a connection between the disc and the brain. There's 4 categories of receptors: type 1, type 2, type 3, and type 4. And I'll just move on because I know we're going to run out of time. Okay. Uh, the 25 discs used in the study were harvested from 15 human cadavers with the mean age of 45 years. None had a history of chronic low back pain. Nerves were not found in 2 out of the 25 discs. Very interesting, 8%. Really want to know why. The receptors most frequently encountered showed Ruffini receptors, which help maintain muscle tone, low threshold, slow to adapt. Okay, it has a very low threshold. It's going to fire, but it's very slow to adapt. But what is that receptor doing? It's helping with muscle tone. What is muscle tone? It's the normal amount of contraction that a person should have in their spine. It's like there's a normal amount of contraction. It's not super tight. That's hypertonic. And it's not super soft. That's hypotonic. It's like keep the slack on the rope and just keep it relatively nice and toned. But it's not by accident. It's by nervous system. That's what there's the other one. Let me mention it first. The second most common receptor is the Golgi tendon organ, and its receptors are activated at extreme joint motion, high threshold, and low adaptation. So when I say that your low back pain was secondary to your brain, when I say that your hip degeneration was secondary to your brain, when I say that your knee degeneration was secondary to your brain, what I'm saying is we lost the tone around the joint before the joint degenerated. We lost the Ruffini mechanoreceptors and the Golgi tendon organs. We lost the connection of the tone around the joint. So all of a sudden, the joint got hypertonic. Something was too tight, or maybe it was too loose. And now the joint is moving through a range of motion that it's not supposed to move through. But you can't feel it for 25 years. You don't feel it until it degenerates inside of the joint. But it didn't start that way. It started when we lost that connection to the brain. The brain is important. That's why you go back and you go to the first article and you see where in the first article they said, look, the people that got the acute care adjustments, which were the only difference between the acute care adjustment people and the so-called maintenance people, was the frequency of the adjustment. The acute care people got 3 times a week for 4 weeks because we needed repetition to get you out of acute pain. But we didn't need repetition to keep you functioning at a high level if you weren't in an acute pain situation. And what did we do to the people in the acute pain phase that we didn't do to the other people? Just change the frequency. That's it. That's why it was one of the stupidest things I ever heard in my life. When COVID hit, I got a letter from the Texas Board of Chiropractic Examiners telling me only do necessary adjustments. I was like, what is an unnecessary adjustment? Like, I don't even know what that means. Like, what articles are you guys reading? Like, what is going on here? You think I spend my life because I run a wellness clinic doing unnecessary adjustments? When I've got randomized controlled clinical trials in Spine magazine that say that people that are getting adjusted are staying better? Like, there's no such thing as an unnecessary adjustment. I just thought I was like, this is from my own board. I don't even understand what that means. Just do necessary adjustments. Okay, maybe they were trying to give us a code. Maybe it was some sort of code and I was, that's what it was. Probably was. They were giving me a code. Wink, wink. Like, just do the necessary adjustments. Okay, that's what I did. That's what I've been doing for 21 years is necessary adjustments because of things like this, right? Free nerve fibers were a frequent finding. In 16 of the 25 discs, 64% free nerve fibers were found. It is assumed that those close to listen to this. It is assumed that those close to blood vessels have vasomotor roll sympathetic tone, while those away from vessels may have nociceptive or a proprioceptive role. That's what they're saying right there is sympathetic stress. Remember, right side, left side brain. It's assumed that those close to the blood vessels have a vasomotor constriction. So what do you mean? What is that? What are you saying, Jason? What does that mean? Let's go back to our brain. We erased it. That's all right. We'll just draw it back. Right side, left side, up and to the right, over to the left, right side brain, sympathetic response. Sympathetic response has an impact in the L5-S1 disc. Blood supply, vessels to the disc. The sympathetic response has a supply to the disc. I'm stressed out, doc. I have increased sympathetic tone. We went back. I almost pulled it up tonight. The article that talks about increased sympathetic tone is tied into almost every chronic disease there is. If you are not getting out of that right brain into that left brain, and then back and forth after that, if that's not happening for you, and you're stuck in sympathetics and you're stressed out, then your low back's not going to function properly. You're going to alter the function of the low back you're going to alter it in a sympathetic response, in a fight or flight response. You're going to alter it to deal with what? A threat. How long is the threat supposed to last? 90 seconds or less ish, right? Your brain gets threatened. It kicks in sympathetics. It says we've got a tiger in the room, and we're only going to have a tiger in the room for 90 seconds. So what am I going to do? Just change up. Just look, the L5 disc, we don't need to just shut it down, increase the blood pressure, whatever you're going to do down there, whatever that sympathetic response is going to be in that disc, just do it because it's only going to last for 90 seconds. Except it doesn't last for 90 seconds. It lasts for an hour. Then it lasts for a week. Then it lasts for a month. And then it lasts for a year. And what are we doing to that disc? We're putting the disc in threat mode for a year. And what does it say? Increased sympathetic response causes chronic disease in all of our body. Increased sympathetic response is an indicator of low back pain. It's a cause of abnormal joint biomechanics all over the body. It's in the brain first. It's in the brain first. It's the status of the brain. It's the function of the brain. It's the movement. Why am I such a big component of moving our feet? Moving our feet, moving our feet, moving our feet. Because it's driving the brain. It's driving this pathway of right and left. It's driving the brain. The brain is now putting the body back in order. It's going back and getting out of sympathetic and getting into parasympathetic. Rest and recover. Rest and recover. Rest and recover. Get away from threat. Rest and recover. Get over on that side of it. We got to get our brain right. We got to get we always have the tie-in. I had a bodybuilder come in today. He said, my right shoulder always sits low, and I got this pain in my trap of my shoulder, and my shoulder seems like it's more forward on this side. It's rolled forward on this side. And what did I do? I had him do the step test right there in front of me. Put your arms out in front of you, close your eyes, start stepping. Which way did he go? It was his right shoulder that was dropped and internally rotated, dysfunctioning. Right shoulder was dysfunctioning. Which way did he go on his step test? He went left. He went left on his step test, which is this way on TV. He went to the left side on his step test, which means his cerebellum and his brain are not firing properly, and that's why his pec is tight and internally rotated and causing his shoulder not to function properly. because it's all tied together. All of it. Your anxiety, your acid reflux, your testosterone levels, they'll tie right into it. Your low back pain and your testosterone levels are tied together. Why? Because you don't need testosterone in a tiger fight. You don't need it if you're stressed out. People tell me, Doc, you need to just get some rest, man. You need to stress. You need to get away and rest. But my testosterone is 568. My A1C is low. My cholesterol is low. My homocysteine is lower, and my testosterone is 568. If my testosterone is 568, neurologically, I'm not stressed out. It's science, right? It's science that says neurologically, I'm not stressed out. If my testosterone's 200, maybe I'm stressed out, but I'm not. I'm not stressed out. And this is not stressing. It might be stressing to listen to. This softball game I'm going to go watch is going to be a little stressful. And if that girl pulls that off tonight, I think that's going to be one of the most amazing feats I've ever seen in sports. If she pitches 3 nights in a row against the Horns and beats them 2 out of 3, I mean, dadgum, that's going to be fantastic. That's all I got for you tonight. I hope you guys have a great weekend. We'll be back Monday night at 6. So holler if I can help you.